Hey now, hello and welcome to a special Chicago Midwinter version of Chairside Live. Chicago Midwinter happened to fall just right into the middle of our Chairside Live filming schedule. I've got to be out there to do a presentation on monolithic zirconia restorations, and so instead of being able to do a regular show, I thought we would do something that I've been meaning to do anyway, and that's dedicate the show to you and your questions. So we have a bunch of viewer mail that we never seem to be able to get around to. Big, thick stacks of viewer mail that you can see here. Questions that you guys have. And since we're doing a remote, I thought it might be a good opportunity to be able to answer some of these questions, because we definitely see some common themes that run through these, and hopefully by knocking out a few of these different letters, we're going to get a bunch of questions answered, because a lot of them are similar, because as dentists, we're doing typically the same 6 or 7 things day in and day out, but we have the same few odds and ends that we do as well. So for example, this first question comes from Dr. Jim Blanchard, and he writes, hey Mike, I keep hearing and reading about how the PFM is as good as dead, and I agree. Well, I would agree for single units, but not necessarily for bridges. In fact, in the next case of the week, a friend of mine prepped a fantastic preparation on his mother and sent it in for a Bruxer bridge. And as you'll see, there might be a rule of 27 violation there, if you recall that rule. And so we might end up still doing a PFM bridge. So I don't do PFM single units anymore and haven't for the last 4 years, but I still do PFM bridges because there's times where a Bruxer bridge just would not be a good idea. He goes on to say, occasionally I've had to perform endotherapy on a previously crowned tooth. Most patients don't seem to mind the occlusal being repaired with composite material as opposed to paying for a new crown. This is fairly easy to accomplish with a PFM. My question is, how will Bruxer or e.max respond to drilling through the crown? And that's a great question, and actually Gordon and Rella up at CR are in the midst of doing research on this right now, and I've seen the initial results from the SEMs, and it looks fantastic. Both of these materials, because there's no ceramic material on the outside of them, do very well with an endo access. You know, with a PFM, the vibration from the burr going through the porcelain caused it to chip and shatter sometimes. It even scared endodontists, probably more than us, because they would be the ones responsible for the crown if, in fact, all the porcelain came off. But with the Bruxer especially, with a round diamond, with a zirconia optimized diamond with the blue band on the shank, when it goes through the zirconia and comes out, there's no chips whatsoever. And e.max has just very small chips, almost unnoticeable, slightly more than Bruxer, but way less than the porcelain fractures that we used to see with some PFM. So that's very easy to do and patch that with composite. But let me throw this out as well. We haven't launched this as an official program yet, though we've done it for some dentists. Let's say you put a crown on, a Bruxer crown for example, and then a year later the patient needs endo. What if you could have the endodontist either take the crown off or do the access hole, and then instead of having the patient have that composite patch, if they were a very picky patient, because we have the design of that crown stored in the cloud from when you prescribed it the first time, we can simply mill you another Bruxer replacement crown so that you could cut the old one off with a hole in the top of it and then cement or bond a new crown right in place, right on top of it. For the patient, probably be no fee if you did the endo, maybe a small fee if the endodontist did the procedure. And all of a sudden you'd have a brand new crown on it with no composite patch on the top again. And so we're saving these designs for the crowns that we mill, things like e.max and Bruxer crowns, and keep them in the cloud for an indefinite period of time. And so anytime you want a new crown for a crown that gets damaged by something like an endo access, you would be able to order a new one if you thought the patient wouldn't be happy with that composite patch on the occlusal. So thank you for that question, Jim. This next letter comes from Dr. Emilio Hernandez, and he says, Mike, I'm familiar with the Ceramer cement being used after the Ivoclean is applied on Bruxer crowns. Well, actually, you don't need the Ivoclean when you use Ceramer, because Ceramer is not affected at all by salivary contamination from the salivary phosphate. So you don't need to use Ivoclean or a primer with Ceramer. But when you don't use Ceramer, he asks, is Bisco's ZPrime Plus or Ivoclar's Monobond Plus always necessary before the cementation procedure? If so, what are the names of some other primers that could be used? It's not always necessary before you cement a Bruxer crown. I often talk about how for the first 2 years basically of doing Bruxer here in the laboratory, which was before we released it and after we released it as well. Every one of the units that I put on with a resin modified glass ionomer with Reliax Luting Cement Plus, and I did not use any IvoClean, and I did not sandblast the internal. I didn't decontaminate it at all. And I didn't use any primers either. I didn't even know ZPrime Plus existed, and it wasn't on the market quite yet anyway, and Monobond Plus was, but I wasn't even thinking about that. And so for 2 years, every Bruxer crown that I put on was just put on with salivary contamination and a resin-modified glass ionomer, and none of them fell off. Now, the reason they didn't fall off is because we had good retention on the preparations. I build up almost every, if not every, prep that I do in one or two different ways, sometimes with a total etch, sometimes with a self-etch bonding material, but I'm almost always building up the preparations as I remove old amalgams and things and clean out underneath and check for decay. So as long as you have good mechanical retention, and I'm going to define that by saying a prep that's, let's say, 3 millimeters tall from the occlusal surface of the preparation to the free margin of the gingiva, and then doesn't have more than, say, 20 degrees of taper. I know we were taught 8 to 10 degrees in dental school, but that's so difficult to measure and so difficult to pull off in the mouth that we're happy if it's not 30 or 35 degrees, to be honest, on a lot of the preps that we get. 20 degrees is fine. 8 degrees looks undercut. I mean, when you've spent time looking at the way dentists usually taper their preparations, when you see 8 degrees, you think, whoa, that's possibly undercut. So if it's 3 millimeters tall on the prep and no more than, say, 20 degrees of taper, you'll be fine just cementing it into place without anything. The rules relating to, or the suggestions, I should say, relating to IvoClean, sandblasting, and the zirconia primers all come into play when we have less retentive preparations. So since Bruxer was designed for lower second molars to replace cast gold, oftentimes you'll have a 1 millimeter, 1.5 millimeter tall preparation, and the distal wall will be tilted towards the mesial because it's hard to get the burr back. Now we're going to want maximum retention. Now we're going to use the IvoClean or sandblast the inside of that crown to get rid of the salivary contamination. Now we're going to use the ZPrime Plus or the Monobond Plus, or you could also use the bonding agent from Kerr's, Optibond XTR, also has the MDP molecule in it. Anything that has that MDP molecule in it, where the P stands for the phosphate, that's going to bond to the internal surface of the Bruxer crown. So really any of those materials with MDP in it will work. What do you recommend cleaning the e.max crowns with before cementation? Hydrofluoric acid, or is phosphoric acid good enough? And how about a primer recommendation for the e.max crowns before cementation? Well, let me order that. Let me answer that backwards. For the e.max crowns, I'm always going to use Monobond Plus. I like to stick within a product family when I can. So if I can use all Ivoclar products, if I am bonding an e.max crown, it will be with Monobond Plus. And it will also be with the multi-link auto-mix cement, and that's their self-etching resin cement. And I'm going to use those because I know they play well together rather than mix and match from different manufacturers. When it comes to cleaning the e.max, let's take a look at what Ivoclar themselves have to say. This is from Ivoclar's scientific documentation on IvoClean, and they're talking about cleaning restorations after trying them in intraorally, and it says the effect of different cleaning procedures on the resin bond strength, the lithium disilicate glass ceramic, which is e.max, has been investigated. They quote a study. The study revealed that surfaces contaminated with saliva are best cleaned with either 37% phosphoric acid or 5% hydrofluoric acid. And so if they also happen to say if you contaminate it with silicone, like Fit Checker, to see where the crown's hanging up, that you're definitely going to want to use the hydrofluoric acid. If it's just removal of saliva, then you can go ahead and use just regular 37% phosphoric acid. Now, you remember that we've mentioned for Bruxer that we don't want to clean the inside of it with the phosphoric acid because that is full of phosphates, and those phosphates will in fact bind to the inside of the crown so that the Monobond Plus, ZPrime Plus won't bond anymore to the inside of the Bruxer. And that's why with the zirconia material, your choices are IvoClean or sandblasting. Another question that got asked in another upcoming viewer mail is the doctor says, I know you can sandblast the inside of zirconia and remove the salivary contaminants. Is it okay to sandblast the inside of an e.max crown? And again, we'll go to the Ivoclar literature. I love going to the manufacturer whenever we have the chance. And in their e.max scientific documentation, you can see a study that they did using 3-unit bridge frameworks that they milled out of IPS e.max CAD. And when they treated them differently on the inside, they ground the inside of one of them, and then they broke all these after cementing them. And then they etched the inside of another one, and then they sandblasted the inside of the third sample. And then the fourth one was pressed, that was etched inside. And you can look down and see one of the conclusions Ivoclar came to: IPS e.max CAD bridge frameworks are significantly weakened by sandblasting. And so I don't recommend sandblasting the internal aspects of lithium disilicates like e.max. And the lab certainly doesn't recommend doing it either. But as you can see from Ivoclar's own documentation, that regular acid etch works just fine to clean the inside of an e.max crown, unless you've had a silicone in there, like a fit checker type material. Then they recommend the 5% hydrofluoric acid. Or, of course, you could use the Ivoclean. In fact, if you go on and look at another study that they did, and all of this, if you go to their website, you can find in the Ivoclean scientific documentation. Here's an e.max crown, a lithium disilicate crown that's been cemented. This is the bond strength that they got when it was not tried in the mouth and it was not contaminated with any saliva. Now, when they took a crown and contaminated it with saliva and just rinsed it out with water, you can see how the bond strength drops all the way down almost by half, or by a little more than half. And then when they clean the inside with phosphoric acid, just regular 37% acid etch, you can say, boom, bond strength shoots back up again, almost to where it was uncontaminated. And then when you use the Ivoclean for 20 seconds on the inside of the e.max crown, their research shows that you actually get a stronger bond than had you not even contaminated it with saliva in the first place. So certainly phosphoric acid looks very acceptable, but the Ivoclean in there tested very well, in fact giving you even a higher bond strength than you could have gotten had you not contaminated at all. And another question that I get is about cementing e.max versus bonding e.max and when to do either of both. And basically, if you look through Ivoclar's literature, they make a recommendation based on the retentiveness of the prep, as we've talked about before, like a 3 millimeter tall prep and no more than 20 degrees of convergence, although I believe they quote 10 degrees, which I think is pretty hard to find in a commercial laboratory. But the other reason when I start to bond e.max is especially in the case of veneers when it gets thinner. And so if you look at a couple of studies that they did, again, this is from their scientific documentation on e.max CAD. If you look at these chart, they milled some crowns and then cemented them on dies and then fractured them. And you can see that the lighter colored bar is zinc phosphate cement. So we're going way back in the time machine. And then we've got adhesively cemented over on the side. And if you look at the e.max CAD, not a huge difference in strength necessarily between cementing it and bonding it into place like we see with the other two. This is one of the reasons why e.max has become one of the most popular materials in the laboratory and in the country, because of the fact that it can be cemented and it does really well. You are going to get a higher load to fracture if you bond it into place, so it will be stronger. But how clinically significant is this? Well, you have to weigh that against, you know, the cost of using a more expensive, say, self-etching resin cement, the cleanup that's involved with that, as opposed to just cementing it on like you would a regular crown and bridge unit. The interesting thing is that if you look at coping, so if we make this thinner, and in this study, it was at 0.4 millimeters thickness at this point. And here you can see at 0.4, which is what you'd see for, you know, a veneer. And you certainly never want to get e.max that thin, for example, on a posterior tooth. But here, when it's in with zinc phosphate, it fractures rather easily. And at 0.4 millimeters, when it's bonded into place, you can see it gets almost all the way up to 1800. Not quite where we were when we had a full crown here, and almost hit 2500 by bonding it into place. But here, the thinner e.max gets, the much stronger it gets, and the more it benefits from being adhesively bonded into place with something like multi-link automatic versus just cementing it with a regular cement at that point. So I would never have e.max get this thin in the posterior. In the anterior, sure, but I'm going to bond all my veneers into place anyway. We're not at the point where we can cement veneers. Veneer preps just aren't retentive enough to be able to do that. So I have friends who bond every e.max crown into place, and there's certainly nothing wrong with that as long as you're not getting any post-operative sensitivity, and most of the self-etching resin cements won't give you much post-operative sensitivity. And that's fine. There's nothing wrong with doing that. I prefer to cement Bruxer and e.max when I can, just because when I cut these off, they're very difficult to get off. And the last thing I want to do is make them even more difficult to get off. So I base my decision whether or not I'm going to cement versus bond on both of these monolithic ceramic restorations by just looking at the prep and going with a, how much retention do I have here? If this is a retentive prep, I'm going to cement it. If this is not retentive, then I'm going to work my way up the bonding ladder. The self-adhesive resin cements are the weakest way to bond something in place. Those are Reliax Unicem, Maxcem Elite, where the self-etching agents are actually in the cement itself. The next stronger way of bonding is going to be self-etching resin cements like Panavia F 2.0 or a multi-link automatic, where there's a separate self-etching step. You mix two liquids together and then put it on the tooth, air dry it, mix the cement, and it goes into place. And then, of course, the strongest way to bond something into place is with total etch, or as it's now called, etch and rinse. But those also have the highest chance of post-operative sensitivity, so you have to weigh that against the retention that you have on this prep itself. So basically, that's where I fall down on all of this, and I think the key thing to kind of take away is good to etch inside a zirconia, good to sandblast it, I should say, the interior of a zirconia crown. Bad to sandblast the interior of an e.max crown. You can clean the inside of an e.max crown with simple 37% phosphoric acid or 5% hydrofluoric acid, especially if you had a silicone inside the tooth. Or you can use IvaClean to clean the inside, and Ivaclar's research shows that you'll get a slightly higher bond strength than had you never had the crown come in contact with saliva at all. So I know that's kind of a broad look with some specific dives into certain topics, but I hope that answers your questions. This next question is from Dr. Brian Burrows, and he writes, Mike, next week I'm removing an e.max MO inlay on a patient. I've tried to find resources on how to best remove a resin-bonded inlay, but have come up short. Do you have a video or guide on how to best do this without removing excess tooth structure or fracturing thin buccal or lingual walls? Thank you, Brian. Brian, no, I don't. I was going to say prep it for a crown, but you said without removing excess tooth structure. Shoot. Really the only way that I've found to do it, and it's actually easier today than I think it was even a few years ago, because of the new zirconia optimized burrs that we have. So, because these burrs, the ones with the blue stripe on the shank, have particles down to 5 microns, the smallest diamond particles we've ever had on a burr, they work really well on the small particled materials like Bruxer and like e.max. And so the safest way to do this is always just to take one of those burrs and just dip it into that e.max inlay. And basically, the safest way to do it is to prepare it as though it were enamel, as you're going in there and removing it like that. There really is no other safe way that I know of to be able to do it, to cut around the edge of it and pop it out, or try to get a spoon or a sickle scaler underneath and pop it out. If it's adhesively bonded into place, it's coming out, and you just need to pretend that it's tooth structure and you're going through it. Probably the easiest way to get into that without just instantly ripping all of the diamond particles off the end of the burr would be with that round diamond with the blue stripe on it. That's typically used for an endo access through an e.max crown or a Bruxer crown. Because of the surface area and the round shape, the outer shape of that round diamond, it does pretty well for kind of digging down into things like that, because you can kind of turn it back and forth as well and use more of the diamond, whereas if you have just a chamfer-shaped diamond that you're trying to push in there, it's ripping concentrating all that force on the tip and ripping the particles off, and it's hard to turn it sideways and get much more. But with the round diamond, it allows you to go back and forth and kind of work your way down. Once you're down there, then I would take the chamfer diamond in and start kind of prepping around the walls and prepping through it. It's going to take a while. Any of these do take a while. In fact, it might be a little more time consuming and take a little more concentration than even cutting off an e.max or a Bruxer crown. I've taken out a couple Bruxer inlays, couple e.max inlays and onlays just to have done it, and there's really no easy way. You're going to have to hope that you didn't do a very good job bonding it into place, if in fact you did it. Maybe the vibration will knock it out. Sometimes you seem to get lucky when that happens. I wish I had a shortcut for you, but there are no good shortcuts here. You're just going to have to cut through it and hope for the best and hope the vibration doesn't, break those thin buccal or lingual walls. And it's one of the reasons why I do prefer, at times, cementing these restorations versus bonding it. If this were cemented, there's a chance that the vibration would rattle it loose as you were drilling through it. But being that it's adhesively bonded, I don't think there's any way it's coming out. You're probably going to have to prep through that whole thing itself, and then I think by definition you're going to end up with a slightly larger prep. I don't think there's any way to get it out, clean it up, and not end up with a bigger prep. Dr. Michael Sheffield writes in and says, "Hey Mike, over the past year I have graduated to using more Bruxer and e.max over PFMs and full gold crowns in the posterior. I'd been gun-shy about all ceramics in the posterior after several delaminations of feldspathic porcelain over zirconia cores. Do you have a decision tree for Bruxer versus PFM versus clinical zirconia versus lava ultimate versus e.max versus obsidian versus etc. in the posterior? I always seem to be torn between having to reduce an extra 1 to 1.5 millimeters for e.max over Bruxer versus the retrievability difficulty of zirconia." Yeah, that's interesting. We're always kind of weighing those things back and forth, but life has become relatively simple for me when I just kind of made the decision that molars are Bruxer. I just see no reason to not go with the strongest crown that we have when it comes time to restore the molars, especially because it has gotten better looking over the years and I think is perfectly suitable in terms of aesthetics for posterior teeth. Premolars, I can go either way. It kind of depends on what's going on with the rest of the case. Anteriors, I'm always reaching for e.max first. Unless one of two things happens, I look in, I see broken PFMs or other broken all ceramic restorations, but especially PFMs in a patient's mouth. Or I see cuspids that are totally flat and the patient's worn them down, especially if the patient's only 35 and is a construction worker, and I see a lot of wear and attrition. I'm like, ugh, I don't know what's going to be able to live here. Or he's broken a natural tooth. If he breaks one of God's crowns, what are the chances that ours are going to do any better? So if I see that, then I'm going to go to Bruxer in the anterior. Unless it's somebody who's got high aesthetic needs, then I'm going to go with e.max. Or a lot of times I'll just explain to them and say, we've got a gorgeous looking crown. We have another one that's not as good looking, but 3 times as strong. You've broken 2 of these. I know you don't want to have to pay for 2 crowns. I'm leaning towards this. What do you think? But certainly when it comes to a single central incisor, it's going to be e.max. It's going to be much easier to kind of blend in with anything else. And something to keep in mind with e.max too, if you are going to use it in somebody's mouth where it looks like they've got a fair amount of wear, but they also have high aesthetic demands, you may want to think about using it in the anterior as a monolithic material. In other words, many laboratories will either press or mill, but typically press an e.max crown, then cut it back on the incisal and layer it with some weaker feldspathic ceramics on the facial to make it look much better. It can rival the aesthetics of Empress when you cut it back and layer it like that. But if they wrap the incisal edge with that weaker porcelain, when the patient functions, those lower anterior teeth will be in contact with that weaker ceramic material, and there's a chance, an opportunity for them to bust that off and actually break it. So my recommendation is to, if your lab's going to cut it back, especially on somebody who shows signs of wear, don't have them cut back and go past the incisal edge. Just do a facial wash. Something on the facial that can go all the way down to the incisal edge if you want, or stop just short, and place that material there on the facial. Or if you were really worried and you wanted to go with e.max, you could just use it monolithic and stained. It won't be as pretty, but it won't have any weaker ceramic material on it because it will be a monolithic material. But when I do see things that are broken in there, if I'm doing 2 or 4 crowns, then I can probably get away with Bruxer. Then again, I've got an in-house dental technician to help me stain it chairside. Help me stain it. She's doing all the staining. I'm doing all the watching. But she can really dial it in and make it look pretty darn good, and sometimes even get close to e.max with 3 times the strength. And so basically, again, for molars it's Bruxer. Premolars, it could be either one based on what we're doing and what I see wear on the patient or something like that. I could go either way, but I'm certainly going to prefer e.max in the anterior until Bruxer gets to the point where it's translucent enough that it can match it in terms of aesthetics and blend in as well as e.max does, because that's really what it does. Then you asked about what are my thoughts on Lava Ultimate amidst all those other materials? Well, for me, it's pretty simple. It's kind of an e.max For single units anyway, it's an e.max and Bruxer world. I still do PFM bridges, 3-unit bridges, especially replacing lower first molars, either because the margins are so far subgingival that to come over that hump of tissue in the middle is going to violate the rule of 27, or perhaps we've had some super eruption of the opposing tooth and now we've got kind of a sway back bridge, and that's going to do much better with a metal framework than it would with a zirconia bridge, even a solid zirconia bridge, where it's going to be prone to fracture at the connection of the ponic and the abutment, and we certainly don't want that to happen. So that for crowns, it's easy for me. It's either Bruxer or e.max, and then I throw the PFM when it comes into bridges. My friends who are doing Lava Ultimate are all CEREC users, and they like being able to do it and polish it chairside, not have to run it up in the oven, and be able to bond it into place on that same appointment, and it looks really good. We just haven't had a lot of requests for it here in the laboratory, even though we've promoted it quite heavily, and my thoughts are with two great materials in terms of strength and aesthetics, especially e.max, which is right in that sweet spot of great strength and great aesthetics. Then you have Bruxer with ultimate strength and acceptable aesthetics. That pretty much covers a lot of different conditions there. And so I think that's the reason why we don't see doctors asking for Lava Ultimate or Vita Anamic. I think these are really chairside CAD-CAM products, but they're serving the CEREC doctors very well, and they seem to enjoy those. And so most of the people I know who are using those, and I've got a couple of each of those in the mouth, but I feel like when I have e.max, if I'm sending it to the lab anyway, why not get something that's strong enough to cement if I want to and looks that good? So since I don't do a ton of chairside dentistry, I really don't have a big use for those two products. This next letter comes from Dr. Stuart Carpanos, and he writes, hey Mike, one of my patients had the porcelain shatter completely off of several PFM crowns that had been in service for more than 7 years. All of these crowns were placed over bicon implant abutments. The copings were not damaged at all. I did not want to cut them off, and I was looking for a minimally invasive procedure to be able to fix this. I made an impression of the copings after some minor adjustments for occlusal clearance and undercuts. Your lab was at first reluctant to fabricate Bruxer crowns to fit on top of these abutments. However, when I agreed to take full responsibility for the result, they agreed to follow my RX. That's funny because we don't advertise it, we don't even promote it a lot, but we have a no-fault remake policy. So anytime we send you any type of restoration, if you don't like it, if the patient doesn't like it, it doesn't have to break, they don't have to swallow it, it doesn't even have to not fit. You can just send it back and say, we didn't like it, make a new one. Doesn't even have to be a big reason. You do have to return the old restoration because we want to check out what happened, but we will make you a new one and correct whatever you think needs correcting. But every once in a while, a dentist will send a prescription and we'll look at it and we'll go, this is never going to work. Why would we know this is never going to work? Why would we do this? We're just going to have to remake it. And we call the dentist. And a lot of times the dentist will say, hey, I'll shoulder this one. I'll pay for the remake. And then we're all, oh, that's fine then. We'll try anything if you're going to pay for the remake, doctor. Then we will go for it. We'll make a crown out of a marshmallow. We'll do whatever you wanted, styrofoam, you name it. That's when we get crazy. We just don't like to be on the hook for the remake. So this doctor's relating when he called in and they said, oh, that's not a good idea. We don't know if it's going to work. And he said, I'll pay for the remake. And we were like, hell yeah. All right, this is on. Let's get going. I think the result was very successful and a good solution for a problem that occurs from time to time in everyone's practice. I used Ceramer to cement the Bruxer crowns over the implant abutment copings. Tell me what you think. Well, Stuart, I think you're a genius, to be honest. This is a really great idea. We just started talking a couple weeks ago about using Bruxer facings to repair a PFM bridge where part of the porcelain pops off of that after it's been in service for many years or even just a few minutes. Instead of a 10 or 12 unit bridge, patients freaking out with a piece of porcelain in their hand. Your crowns did a little bit better. They were in the mouth for 7 years, serving well, sitting on top of implant abutments, and then all three of them eventually busted, and you were looking for a way to not have to, rip everything off and start over again. So you prepped off what was left and then reduced occlusally and axially. I actually saw a couple pictures of the dies when they came through, and so there was actually 3 teeth. There was tooth number 19 and 29 and 30. And we were, a little concerned about some undercuts, and so we did a little die spacer and blocked out to make sure we wouldn't be into any undercuts. And then when the case went out, we had Bruxer crowns fabricated for you right on top of what you prepped and left us, and you cemented those right on top of those copings that were on the abutments, and that's just an absolutely fantastic idea. And this is the first time we've seen this actually documented by one of our dentists. So I want to thank you for coming up with that solution on your own without me throwing it out there first. And I think it was really ingenious what you went in and did. And I don't know what you charged the patient or if you charged the patient, but you probably charged maybe not as much as you would for a regular crown, so you did them a great service. I don't think you're going to see the Bruxer crowns break. As long as they were 0.6 of a millimeter or thicker, they should survive very well back there. And Ceramer does bond to metals as well as it bonds to Bruxer, so I think you made a good decision there as well. And I think you came up with a really unique way to solve something that we all do see from time to time, but don't specifically see it on implants. And so I forwarded your email to the implant department so that all the technical support people who work the phones in that department, next time they have a dentist call in and say, hey, I had a PFM break on this implant, what are my options? We now have the ability to do this Bruxer over crown on it if they're conscientious enough to prep as much as you did and leave us some room so we can get that done. So thank you very much, Stuart. We appreciate it when our customers teach us something. This next question is from Dr. Jason Bullock. Jason writes, hey Mike, you mentioned using a PVS impression of a wax up and Luxatemp to get the ideal contours of the tooth prior to preparation. If the tooth is very deficient in form, so it'd be in lingual version, and you use the Luxatemp as your buildup, when you do the prep and say your 2 millimeters of reduction is still in Luxatemp, since Luxatemp does not bond to tooth structure, what do you do about that? If it doesn't bond, it won't serve as a suitable core, will it? It seems to me that if your reduction is in Luxatemp, and that will come off your prep, and it will still be less than ideal. I hope that question makes sense. Also, I saw in one of your videos you talked about pre-contouring prior to veneer preps and mentioned that teeth that are lingually placed could have composite added prior to the prep. What's the best way to do that in your experience, and wouldn't that result in the veneer prep margin being in composite? Thanks for your time. Love the videos, Jason. Well, Jason, to answer your question, let's look at an actual model of somebody who's got some rotation issues and some teeth to the facial and some teeth to the lingual. So yeah, you're barking up the right tree. Your question essentially is, if we build up here with composite or Luxatemp, I mentioned using a putty wax matrix of the diagnostic wax up, which would add Luxatemp to this tooth to bring it into ideal arch form. And then I said we place a depth cut right through that. So even if we did a 1 millimeter depth cut here or a 1.5, and you're saying if the Luxatemp was 2 millimeters thick, like if this tooth was really back to the lingual, and so it didn't go all the way through and there was still 0.5 millimeter of Luxatemp, the Luxatemp's not going to stick to the tooth. What do you do? And you're asking, well, even if the Luxatemp falls off, which it will, you still don't have an ideal prep, right? Because it's too far back to the lingual. And you are correct. Really, the Luxatemp, for the most part, is just kind of a basic prep aid. And you're right, it is going to fall off as you're prepping it. Even if it doesn't, you're going to knock it off because you can't bond to it. And so you are going to end up with something that's a little more deficient on the facial and a restoration that's a little thicker on the facial as a result. What we used to do at David Hornbrook's wonderful PAC Live course, all the students would take a patient like this, and you would use like an orthodontic arch wire, which has a perfect arch form on it, or you could have a D-wax from your lab, or basically you would just freehand it because the exercise was so good. And you would take a patient like this, and you would, you could do it without anesthesia depending on how much you had to remove, but you would look at the teeth. Like, for example, you can see these cuspids. This one especially is a facial limiting factor by how far that is. So if we were just going to prep 1 millimeter on all these teeth, just pretend we were going to do 1 millimeter on all these teeth because they were all in the same arch form, we would have to do more here, maybe 2 millimeters, because that's got to be moved back farther to the lingual if we're going to have it blend. We can split the difference if we end up doing no preps on these two teeth, so that's something to consider as well. This tooth, you can tell, is back to the lingual. Are any of these in the right position? It's a little hard to tell. We got a rotation here. The mesial, this is rotated towards the labial. That tooth's probably the closest to being in correct position. Of course, a big rotation here. And actually, this cuspid is probably pretty close to where it needs to be. And so what we would do as an exercise would be, On teeth that were deficient on the facial, you would actually bond composite onto here and freehand it on. So you would freehand composite here and literally bond it to the enamel and bring it out until the tooth looked good there facially. Then you would come back to the lingual and you would remove tooth structure until you got rid of that rotation. So essentially we would prep away the rotation by adding a composite here where we're deficient, and then it would taper out as we got to the distal, and then prepping the lingual along this line angle and removing tooth structure until we in effect did instant orthodontics on that tooth and rotated it. On this one, you can tell it kind of needs to be rotated this way, so we would add some composite here and remove some tooth structure here, and might even need to add a little composite here, and you would work your way through here and you would add composite here, and again you're really adding it. You're acid etching the enamel, and you can skip the primer, go right to the adhesive, and then freehand that composite on there so the facial looks perfect with this arch form. So you can match a diagnostic wax up that you have, or you can just draw it in your mind or draw a pencil on the incisal edges with that ortho arch wire to see where it needs to go. And then we would add our composite here till it looked good, and then prep the back of this with a football burr till it matched the lingual arch form. And then once you had corrected all these rotations, either by adding composite or removing tooth structure, so that you now had everything in a perfect arch form, now you could go ahead and place your 0.6 millimeter depth cuts everywhere. Anywhere on the lingual where you got down to dentin, that veneer is going to have to be connected around over to that side, of course, when that happens, if you're going to be that literal about it. But most dentists that I talk to just leave the lingual alone, even if it ends up being a tooth that's going to be thicker than it needs to be. They're more concerned with how it looks on the facial. And so really the patient's tongue is already used to what this feels like on the lingual. So if we make all the necessary changes on the facial by bringing back anything that's too far out to the facial and having a slightly thicker crown than ideal on this tooth to bring it out to the facial and make it match, that's usually what most dentists are going to do and not worry too much about what's going on the lingual surface. But to kind of wrap that into your question, Jason, now if we put a depth cut in here and we're still not all the way through composite, that composite is bonded onto this enamel. In fact, that's bonded as strong to this enamel as it would be if it was a buildup bonded to dentin on a crown prep on a posterior tooth. And you're correct that we're going to have to get a margin that's not in that composite, and we'd like to go a millimeter beyond that. So we'll often stop the buildup right around here, and the combination of going slightly subgingival in the aesthetic zone is going to make it so that we've got our margin on solid tooth structure at least a millimeter beyond where that composite that we added, so that we don't have to make a restoration that's too bulky. That's going to be bonded to the tooth, and I'm very confident in that as a buildup material, Jason, even though it's not a buildup for the traditional reason. Usually it's because we don't have enough tooth structure, but in a sense we don't have enough tooth structure here, so that we want that restoration to be a uniform thickness all the way across the front. If we have an e.max veneer that's 0.3 of a millimeter thick here and 1.2 millimeters thick here, the light can't help but react differently optically when it hits it, and those two tooth surfaces can look a little bit different. We'd rather have a uniform thickness on the facial surface of these restorations to make sure that that it really looks nice. Again, on a regular case, this might be something that seems over the top or too much time with the patient. You could always do it on a stone model before they come in to just get an idea of how much you're going to have to reduce on this tooth as well. And this really commits you to aesthetics. If you're going to remove 7/8 of a millimeter on this tooth to bring it back where it needs to be, and then prep a full millimeter on that afterwards, or a crown and do 1.5, there's a chance that you might end up doing an intentional endo in the name of aesthetics. So you kind of have to balance out, how important is aesthetics, how important is perfection to the patient. Maybe I can reduce less here if I put 2 no preps over here and bring these out to kind of fill that buccal corridor, because those teeth already kind of disappear, and they're really going to disappear when we have veneers on these 2 teeth. And that's why one of the things, at Pack Live we always learned was you either do 4 veneers, these 4, or you do 8 or 10. Stopping here at 6, these teeth will always disappear and never look good. We just did 4 on a woman the other day who came in and said, I thought she was blaming it on these 4 crowns. She said, something's wrong back here, and she couldn't see it. We didn't do anything to the cuspids. She just noticed by looking at her teeth so much that her buccal corridor was dark because of the bicuspids, and so we put some no prep veneers here. to kind of fill that out and round it out. We ended up doing some on the cuspids too because the shade was too dark compared to everything else. But it is one of those things that gets you to think about how you're going to prepare this. If these were old crowns that we were replacing, your job becomes a lot easier because you're prepping all the lingual as well. But you still want to give the laboratory enough room and not just prepare what you usually do. You want to give everybody enough room, and so that pre-contouring gets you to an ideal arch form. Basically what you're trying to do is make it like those veneer cases where everything is perfectly in line where it needs to be. We just have tetracycline staining or white spots from fluorosis. Like we're doing veneers simply for aesthetic reasons, and that's the time where we can go in and do a 3/10 millimeter depth cut or 6/10 on all the teeth exactly the same all around, because we're going to prep them all back the same amount because we want them all to come out the same amount because the arch form is perfect. This is the way to correct that arch form before we start the treatment so that we have a better shot of ending up with a really nice aesthetic case. Well, that about wraps it up for this very special episode of Chairside Live. I know a very special episode usually means that I fall in a well and Megan's dog Parker barks a lot and she comes and rescues me, but that's not what happened. I've gone to chilly Chicago all on my own while she stays home and luxuriates in warm Southern California, but it gave us a chance to get through a bunch of old viewer mail that we hadn't had a chance to get to. Keep the letters and comments coming. Please, if you think of something ingenious to do with one of our products, take some pictures, send it in. We'd love to give you some props for that. We learn from you guys more than you learn from us. And so we'll be back next week in California. Megan will be here. We'll have all the regular segments, and I look forward to seeing you then on Chairside Live.